So thank you again for the introduction. Today's presentation will be using pharmacogenomics and family medicine with pediatric populations. And this will be with Dr. Lucas Berenbrok and myself. We do not have any disclosures to report. Just some brief learning objectives for this didactic portion. We'll be evaluating the principles of attention deficit hyperactivity disorder, or ADHD, in the pediatric population, understanding ADHD treatment options and considerations for pediatrics, and then reviewing the CPIC guidelines for gene-drug pairs that are relevant to the subsequent case presentation, as well as briefly discussing phenoconversion and potential implications for medication management with pharmacogenomics. So with ADHD, care should be coordinated between the patient, providers, parents, and the caregivers. And within the pediatric age group, teachers and/or representatives from the school may also play a role. The main goal of this care coordination is to establish treatment goals as they are specific for each child. And as such, management and monitoring may vary depending on those same treatment goals that are established. Due to age, adverse effects, and responses experienced and seen on treatment is how we'll monitor our patients. Treatment modalities range from pharmacology and behavioral management, which may include maintaining schedules, setting goals, rewarding positive behavior, limiting choices, using calm discipline, and also combination therapy with both playing a role, especially while we're trying certain medications and we may not yet be at an optimal dose or response. And the prognosis of ADHD in the pediatric population has periods of remission and recurrence, but with early interventions, especially with care coordination and those established goals, outcomes may be improved for adulthood. And just to note, hyperactivity and impulsivity usually peak around the ages of 7 to 8 and then begin to decline, but impulsivity may remain and persist throughout life. So some clinical features of ADHD include that hyperactivity and impulsivity, which can be seen with difficulty remaining seated, restlessness, and excessive talking, and then also inattention in more than one setting. And this may be an inability to maintain attention, poor follow-through, and difficulty listening. The diagnostic criteria for ADHD may be based on behavioral scales and/or the DSM-5. So we have ADHD-specific behavioral scales that are also considered narrow band. So they focus specifically on ADHD symptoms. And there are some scales that are from a teacher's perspective where they monitor attention problems, hyperactivity, lack of social skills, and oppositional behavior. And then there's also a rating scale based on the symptoms seen in the DSM-5. There are also broadband scales, and these assess behaviors that may be associated with ADHD, as well as internalizing behaviors, which can be seen as depression or anxiety. There's also a teacher report form in these broadband scales. And again, they're assessing social, thought, attention problems, any anxiety or depression, withdrawal from social settings, and then even aggressive behavior. And then other behaviors assessed by these scales include inattention and hyperactivity and impulsivity, peer relations, executive functioning, and then lack of adaptability. And with the DSM-5 criteria, we would want to see 6 or more symptoms of hyperactivity and impulsivity, or 6 or more symptoms of inattention. And those are some of those symptoms on the left side with the clinical features. And with treatment goals that are established, they should most importantly be realistic and measurable. Again, this is part of that collaboration between the patient, the caregiver, the care team that can include teachers or representatives from the school. And these are really useful in monitoring response to treatment. So when it comes to the treatment of ADHD in pediatrics, the time before treatment starts can be just as important as the treatments themselves. This is the time that we really want to make sure the patient and caregivers and members of the team really understand the risks and benefits of treatment. Some of the risks that we may want to bring to their attention is that there is still some uncertain associated risks of stimulant use and cardiovascular symptoms, as well as the more common adverse effects we see with certain medications, including decreased appetite, leading to weight loss, insomnia, and then in some cases, we may even see the development of tics. We also do want to let them know the benefits, which can include the fact that this patient will be able to control themselves and be able to focus and may have improved outcomes in life. And then, since this is a pediatric population within school as well. And it's also really important to stress how much time finding the best treatment may take. So when starting a medication, it could take anywhere from 1 to 3 months to determine the best medication, the dose, and the frequency. So during this time, it's necessary for them to know that there will be many follow-up appointments. And during these appointments, we'll address those treatment goals. So that should be something that they're monitoring as well, so that we can address those in those follow-ups and see where we're at with the medication and whether or not it's working for the patient. So when choosing a treatment, there are multiple factors to consider since they all play a role. So we really want to know what is the duration of desired coverage. Do they want coverage just in the morning, during school and at home? So that can help us also figure out what time of day we want to target. Do we want a short-acting or a long-acting stimulant? Another thing to factor in is whether or not our patients in the pediatric realm can swallow a pill, whether they need an oral solution, or they need capsules, a patch, orally disintegrating tablets. That can also play a role with what's available and then the expense. And again, patient preference. And as well as I'm sure we're all aware, there's been many shortages for ADHD medication. So taking that into consideration as well. And again, we also want to find out from the parents and the caregivers whether or not they want to administer the medication at school, whether or not there are any coexisting conditions, whether those be emotional, behavioral, or physical, such as an existing tic disorder. And then we also want to know before starting any medications, whether there are any known cardiac risk factors, as well as what their resting heart rate and blood pressure are. And again, we will also focus on the side effects that can play a role with these medications. Although at this time, genetic testing is not recommended prior to initiation of any treatment, again, it may help guide decision-making, especially when factoring in concomitant medications that may lead to some phenoconversion or increased side effects. So typically in children 6 years of age or older, treatment is initiated with stimulants, and sometimes that's also in addition to behavioral therapy. However, as mentioned in some cases, and then considering factors such as preference and timing, non-stimulants may be appropriate as first-line treatment. Some of the medications and the classes that are used for ADHD, we have some selective norepinephrine reuptake inhibitors, or SNRIs. So we have atomoxetine or Strattera, and then also viloxazine or Quellbri. We have stimulants, so those include methylphenidate, dexmethylphenidate, amphetamine, dextroamphetamine, and then the combination. So some brand names that may be more familiar, we have Ritalin, Adderall, different patches, so Daytrana or Zellstrom, Cotempla, Jornay. And then we also have alpha-2 adrenergic agonists, so we have guanfacine and clonidine. These are FDA approved for monotherapy as well as adjunct therapy. And then they may need some more time to reach steady state compared to our SNRIs or stimulants. And it's important to note that these also cannot have drug holidays, which can be common in the pediatric population. So bringing it back to the medications that we may talk about in the subsequent case presentation, atomoxetine is a norepinephrine reuptake inhibitor. So it is indicated for ADHD as well as social phobia with ADHD. It's a good option for treatment due to it being relatively well tolerated and studies showing increased concentration and decreased impulsivity in participants. It is extensively metabolized by CYP2D6 to its active metabolite. And for the CPIC guideline, it was published in February 2019. It includes recommendations for adults and adolescents 18 years of age or less. I just wanted to bring our attention to the specific recommendation for atomoxetine in children. This will be relevant for the case presentation later on for CYP2D6 normal metabolizers with an activity score that ranges between 1.5 to 2. So the next medication I wanted to bring your attention to is sertraline. It is a selective serotonin reuptake inhibitor, or an SSRI. It is indicated for many conditions such as major depressive disorder, generalized anxiety disorders, and panic, among many others. The metabolism of sertraline implicates many genes, including CYP2B6, CYP2C19, CYP2D6, and CYP2C9. So this is the metabolism of sertraline to its active metabolite shown here. So the CPIC guideline for serotonin reuptake inhibitor antidepressants was actually published in April of 2023. So this includes recommendations for CYP2D6, CYP2C19, and CYP2B6, and many commonly prescribed serotonin reuptake inhibitor antidepressants, which does include sertraline as well as some others such as paroxetine, escitalopram, and venlafaxine. And again, I wanted to bring your attention to specific recommendations for sertraline based on these phenotypes. And I do also want to mention that depending on the pharmacogenomic panel used for testing, whichever genes that they do test, you may not always see CYP2D6, CYP2B6, and CYP2C19. So sertraline has recommendations based on the CYP2C19 phenotype here. It also has recommendations for CYP2B6 alone. And then it also, if you have both phenotypes, has recommendations for CYP2B6 and CYP2C19 together for sertraline. And just as a brief mention, as I'm sure Dr. Berenbrok will go over during the case presentation, in our clinic, we use CPIC recommendations. However, there is still the FDA table of pharmacogenetic associations. And I just wanted to kind of briefly put this in here. There is a recommendation for amphetamine, but this is more informative for CYP2D6 poor metabolizers only. So within CPIC, it's only a level BC with provisional status, so we wouldn't use it in our clinic, but just wanted to bring your attention to the fact that there may be some recommendations outside of CPIC alone. Lastly, phenoconversion has been a topic of discussion within pharmacogenomics and especially in clinical settings. So this is the occurrence of a mismatch between a patient's predicted genotype and their phenotype. So this may be due to certain concomitant medications and comorbidities. So due to this potential mismatch, the CPIC recommendations may need to be adjusted. It may not be as straightforward as just matching the phenotype to the recommendation. And in particular, I wanted to bring this up because CYP2D6 is susceptible to inhibition, and atomoxetine is metabolized by CYP2D6, and sertraline is considered a moderate to weak inhibitor of CYP2D6. So that's something to take into consideration.